Good morning, everyone. My topic is smaller versus larger, which is better for therapeutic penetrating keratoplasty in microbial keratitis. I have no financial disclosure. Introduction: microbial keratitis is an important cause of corneal blindness in India. The infection usually occurs following ocular trauma and contamination of corneal lesion. Microbial keratitis is often difficult to manage with medical therapy alone. The important reason for poor response to medical therapy is the delay in diagnosis and lapse in early institution of the therapy. Hence, therapeutic penetrating keratoplasty is required in cases where topical medication failed to eradicate the infection. The success of keratoplasty in the active stage of infection has several limitations. An important cause for failure of keratoplasty is the recurrence of infection after surgery, with reported rates ranging from 5 to 14%. The purpose of the present study was to analyze the outcomes of therapeutic penetrating keratoplasty performed consecutively for non-responding fungal keratitis. The aim is to compare the outcome and results of therapeutic penetrating keratoplasty using larger donor grafts of size more than 8.5 mm versus smaller grafts size of less than 8.5 in patients with recalcitrant microbial keratitis in a tertiary care center. Materials and methods: it's a retrospective study, time period from June 2019 to May 2020. A cohort of 20 eyes of 20 patients that underwent therapeutic penetrating keratoplasty with a graft size of more than 8.5 mm was compared with 20 eyes of 20 patients undergoing therapeutic PK with graft size of less than 8.5 mm. The medical records were reviewed thoroughly for the demographic details, risk factors, size of ulcer, microbial investigations, donor graft size, post-op complication, and anatomical and visual outcomes. These are the few pre-operative photographs of the patients with microbial keratitis. And this is the post-op after undergoing therapeutic PK. We can see the first picture, the graft is clear. This is 1 year post follow-up therapeutic PK. We can see the clear graft. Results: both cohorts were comparable for age, sex, and ethnicity. Age of patients ranged from 16 to 60 years, and average follow-up period was 1 year. The anatomical integrity was achieved in all patients. The preoperative visual acuity ranged from PL to 6 by 60, and post-op VA remained same in 23 patients. It improved to less than 6 by 60 in 7 patients and was more than 6 by 60 in about 10 patients. In the first cohort, that is a graft size of more than 8.5 mm, in 14 patients the graft was clear. 2 patients had graft failure, 2 had infection, 1 had wound leak, and 1 patient had wound dehiscence, and 3 patients developed secondary glaucoma. In the cohort of graft size less than 8.5 mm, in 8 patients the graft was clear. 5 patients had graft failure, 4 had infection, 2 of them had weak, and 1 patient had wound dehiscence, and 1 patient developed secondary glaucoma. Now here is we can see that in graft size of more than 8.5 mm, the proportion of patients having a clear graft is more than the cohort having graft size of less than 8.5 mm, but the chances of secondary glaucoma is, here 3 patients had secondary glaucoma in smaller graft size as compared to the 1 patient with secondary glaucoma in graft size of more than 8.5. So the larger donor grafts, conclusion: larger donor graft has better functional outcome in patients with microbial keratitis undergoing therapeutic PK as compared to smaller grafts, except for secondary glaucoma, which was more common with larger grafts. Therapeutic PK has a definitive role in management of severe keratitis with huge success in restoring anatomical integrity and providing useful vision. Thank you.
How many of the patients had bacterial and how many were fungal, and the patients undergoing keratoplasty?
Ma'am, not written.
How many were bacterial, how many were fungal?
Ma'am, most of them were bacterial and like second combination.
And did the post-operative regimen differ in the patients? What did you give them?
We've given immunosuppressant drop, cyclosporin drop was given, and then antibiotic, and fungal cases we've given natamycin drop and
fungal cases?
Natamycin eye drop we've given.
Where steroids started at some point?
Yeah, steroid drop, prednisolone drop.
So what is your protocol of starting steroids for fungal keratitis, therapeutic PKs operated for fungal keratitis?
In fungal keratitis, we are not giving immediately a post-op, we are not giving a steroid drop. In bacterial, we've given prednisolone drops.
So I feel basically the etiology would also make a difference in the graft outcome, yes. Because obviously fungal if they are associated with perforation or impending perforation and lot of infiltrates and inflammation, they are likely to do much worse related to the etiology. Similarly, virulent bacterial like Pseudomonas or against with perforated ulcers, they are likely to do much worse than the other ones. So not only it depends on the graft size, it depends on several other factors also.
Yes.
Yeah.
I just have one quick question for you.
Yes.
It's a retrospective analysis.
Yes.
How did you work on the sampling of 20 each?
We have taken from the the data itself.
It
we have
is
taken
just
20
like that, or you planned for 20 only?
We've taken a planned for 20.
Yes.
Yes.
Thank you.